The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between.
Hi, George. It's good to see you back on the show. We're all very sorry about your recent loss.
That's okay.
Hope you're feeling better, and we pray for your dad's soul.
Yeah, thanks. Well, today we have Dr. R. Brett McQueen, like Steve McQueen. And the topic of discussion is kind of hard. Applying a mathematical formula to quantify the value of medical interventions. Wow, that sounds like PhD stuff.
Dr. R. Brett McQueen is an associate professor at the University of Colorado Skaggs School of Pharmacy and Pharmaceutical Sciences, specializing in health economics and outcomes research. As a director of the Center for Pharmaceutical Value, he concentrates on implementing and evaluating innovative approaches to improve pharmaceutical coverage and reimbursement decision-making. Dr. McQueen's research encompasses comparative effectiveness, cost-effectiveness applications, and patients' preferences, with particular interest in multi-criteria decision analysis for healthcare decision-making. He works collaborating with the Colorado Department of Healthcare Policy and Finance to negotiate and oversee value-based contract, word which I don't like, aim at improving the patient health outcomes and lowering prescription drug costs. He also researches the effectiveness of early screening autoantibodies to prevent DKA diagnosis in type 1 diabetes. Welcome, Dr. McQueen. It's a pleasure to see you again and excited to touch on all these very important yet really foreign concepts from a pediatrician standpoint.
Thank you for having me. Hopefully we'll provide some demystifying discussion on what I do and how it might be applied to your work.
So why a PhD in pharmacoeconomics?
Yeah, so pharmacoeconomics is a whole field that spans back. It is a young field that spans about 40 to 50 years rather than a lot of the well-established fields, but it's interdisciplinary. It involves understanding decisions made at a population level. So how do we navigate a whole formulary set of drugs in terms of costs and the benefits? Are there ways that we can, in some cases, actually directly negotiate? Manufacturer. So this drug works, we'll pay you the full amount. If it doesn't work, can I get some sort of a rebate or money back? So I actually do that in practice. You mentioned in my intro the healthcare policy and financing, which is really Colorado Medicaid. And so I actually design payment arrangements and for highly specialized technologies. Again, how do you get into an arrangement that if a drug or an intervention doesn't work, do you get some money back? So it is a whole field. It's definitely behind the scenes. But in terms of reference to pediatrics and type 1 diabetes, I actually have been working in type 1 since my dissertation back in 2008 to 2013, where I looked at the diffusion of continuous glucose monitors in the population and how CGMs would either be cost-effective or not be cost-effective at the start, and what are some of the things that needed to happen in terms of a technology perspective for that to be more cost-effective. Maybe there were subgroups that, it was more efficient to use CGMs. So that was definitely part of my work for years. And then more recently, I got involved with a large-scale autoimmunity screening for kids program, Denver area, and understanding the economic trade-offs of expanding general population screening.
And help me understand, because from our perspective, when we negotiate with payers, all we hear is you're just adding expense to us. So my 2025 word of the year is impact, because there are certain things that in my mind we can spend money on, and I'm going to spend more money today, but they have a great impact. Like the commercial says, priceless. So if I can prevent DKA and I don't have a crying mother telling me why she didn't know, and I spend an additional $70 to screen the kid, to me that's tremendous impact. I care less if we spend the $70, and my analogy is, well, if you go to Starbucks and spend $8 every day, in the course of 2 weeks you spent that $70. Why wouldn't you spend it on a child? So when you work with Medicaid, how do they see spend versus impact?
Yeah, I think the first thing to note is what you're describing, in my opinion, is more ethics rather than economics. So should we do something? Is it, better for society if children don't end up in DK in a hospital environment? That's a should question. It's not really something that we address, but I think where you're going with this, which I appreciate, is how do you sort of plan for changes in budgets if something is determined? A buzzword is after the CMS drug negotiation program. And really before that, a lot of what we talk about is unmet need. So what's the unmet need in a population of pre-symptomatic type 1 diabetes patients? And what we do is, for any kind of coverage and reimbursement entity like Medicaid, is not only understand how your budget change over time, so in terms of added cost to the system, but also what are the offsets that we would expect to see. And in certain scenarios, when will you break even? And those messages are a little bit better directed towards payers. They're at least more willing to consume that information on top of whether there's an unmet need. So there's always the first benchmark. Is there an unmet need? Is there need for improving the effectiveness in this particular population? And then after that, it's okay. If so, then what's the budget impact that I'm looking at? And is there a way that we can improve on that budget and potentially reduce spending to a point where it's either neutral or it's a small budget? So I think those are kind of conditional on that first statement. And how we help Medicaid is, I think I mentioned this earlier, that we look at specific payment arrangements, and they're often called outcomes-based agreements or value-based contracts, where what we do is simulate different scenarios in the future and say, if you figured that you covered this and you entered this agreement, how much would your budget change over time? Should you ask for a bigger rebate if it's going to really impact your budget dramatically? So again, our questions are, once you've decided what you want to do, how do we quantify the impact on your budget, on the potential value to patients in that subgroup? And we can get into this more, but one of the challenges in screening for type 1 is you're screening a huge population and catching a very tiny group of people that transfer to type 1 diabetes. So how do you make it as least expensive as possible up front, while also giving the patients that are positively identified the right monitoring and education for it?
The people that you negotiate with are generally not clinical people. They're numbers people. And they look at, if I do this, how much money do I save, or what is it going to cost me if I do this? So they really don't care. Am I going to make a child better or not better?
I'd actually disagree with that, because most of the people we work with are either pharmacists or MDs who are working for the health plan or the population decision maker. And they're usually the clinical group walking in and saying, okay, how do we cover this? And how do we make it somewhat budget neutral? And it's not that they don't care about health outcomes, it's that they care about health outcomes for the entire group of people that they're covering. So if they spend so much attention on, say, children with type 1 diabetes, then, and I can tell you this from experience, then another group of people will say, well, what about this childhood disease that you haven't spent any money on? So I think the general idea is they are looking at population health from a very broad lens. And they're presented with individual cases over and over again. And then they have to make these really complicated decisions, all with what I think are unrealistic constraints provided by the US government. And, really it's difficult to look at value when the US government has policies that prevent us from doing so.
Yeah. So budget impact, I think if I got it right from your lectures, is measured in a per member per month amount. So
Yes.
if I start screening for type 1 diabetes, it's going to cost $1.50, I think is what you have come up with per member per month, additional cost across the board, all Medicaid, commercial, all of them.
Yeah.
And that's how the accounting goes.
Yeah, let me explain that a little further because budget impact is a direct reflection on the premiums that we contribute as plan members. So every one of you is likely either part of a government entity that provides healthcare, or maybe it's a private entity that provides healthcare. Your employer contributes a certain amount of money each month, and you pay a premium every month. There are alternatives to that, of course, like high deductible plans where there isn't really a monthly premium and you are exposed financially to events and activities that may occur from health that then you have to pay for out of pocket. All sorts of varieties of those. But generally, insurance, if we're going to expand and include more interventions, you would come together and say, these are all the new interventions that are coming at this health plan, right? So we have childhood screening for type 1. We have new drugs for, chronic diseases. We have all this stuff coming in, and we have to have some increase in our premiums to be able to cover the budget of those interventions. Now, you certainly could argue, and people successfully argue, that a lot of insurance companies are making a profit, and people may feel like it's unfair that we are paying premiums that go towards their profit and then, things get excluded or certain interventions are, restricted. Those are totally fair arguments, but we also have a choice to go to different insurers. There are lots of choices. We actually have that choice, not only through individual employers, but through marketplaces for insurance. So separate from that, generally that budget impact, the per member per month, then flows into these sort of what increase in premium do we have to establish for every member, not just people with type 1 diabetes, every single member in order to cover that screening approach, regardless of what that screening.
And then from the Medicaid side, the state has to decide, this is going to cost me X dollars per child that I have on Medicaid. Is that something that I can get through their Congress or the Senate or whatever their budgetary approval process is to fund it?
Yeah, every year there's a new budget and that has to be approved from state lawmakers, and they don't necessarily get into individual interventions. That's more covered at the Medicaid level, and their responsibility is to stay within the budget that was allocated to them. But there are situations where certain Medicaid departments will go back to their state and say, we need more money to cover our plans. And that especially happened during the extension period for Medicaid.
And then another term that you introduced me to is cost effectiveness analysis.
Yep.
And there's a specific math formula for it.
There is a formula. There's a lot of steps before the actual formula, but generally it's the difference in cost over the difference in effectiveness. And what that gives you is what are we spending and then what are we receiving in terms of health benefits. So if that is positive, usually what we see are interventions that cost the health system more money, but they also produce health benefits. So that's important to note because there are some interventions, and this goes back to a point you made earlier, there are interventions that actually save money and are more effective and are actually not even included in our healthcare system because of certain established reasons among physicians or clinical guidelines. There are a lot of low value care options, and they're just, not, for whatever reason, they're not being used in our health system. And there's been some evidence presented.
And within that, time is not a factor. Because you might have an intervention, let's say the HPV vaccine, it prevents cervical cancer, but we give it at 9 years of age. no one gets cervical cancer at 9.5, 9.75, 10,
Yeah.
10.25. But that person is not going to have cervical cancer, throat cancer, anal cancer by the time they're 25 or 30. And then it's not measurable because they didn't have the event that cost any money to the system. So how do you compensate for the fact that not every intervention has results that are immediate? Some can take years or decades.
Yeah. It's a really good question. That's why the standard sort of what we would call time horizon is lifetime for cost effectiveness analysis, because a lot of interventions actually don't really produce differences against usual care in terms of outcomes for years. There are a lot, not just screening. But for example, in type 1 diabetes, most of the evidence before I had kind of walked into the field was just about the economic viability of screening and then preventing a decay event. And yet there was a ton of evidence that I've personally found and that is actually coming out from screening programs, not just in the United States, but for example, FRIDA in Germany, where you're seeing differences in glycemic control for those with and without a decay event. So that are persistent for years. And the general idea there, right, is that there's some beta cell preservation. There are some other biologic reasons that you both understand. That's less my area, but we work directly with a lot of both adult as well as pediatric diabetologists to understand whether that impact really lasts for years. And there's evidence that it lasted well past 20 years. And so we were able to, in our paper, actually model what you could call glycemic memory over time, so that if you were to screen a child now, we don't want to wait for 50 years to cover screening. If it works and it's not only effective, but it's cost effective, we really need to make that decision within the next day, in my opinion. And then once we make that decision, we should be basing it off of not only what are the cost offsets and reductions in decay event now, but what about in years in the future, right? Like, what's the difference in their survival that we should expect between somebody with a decay event and without? So that is actually really standard in cost effectiveness, and we would do that for any of the vaccines, not just for, say, screening.
So you take it out through the lifetime. That's a time horizon. Because I understand, thinking more just like a doctor. If I can prevent DKA, that's about a $50,000 spend on the acute care in the hospital. And so all I have to do is, show that I prevent DKA, and then that should be cost effective. But, what you're saying is you want to go beyond that and show that getting closer to target of your hemoglobin A1C decreases the number one cause of blindness in the U.S. over age of 20, which is diabetic retinopathy, decreases microvascular injury. Therefore, it should decrease cardiovascular injury to patients with diabetes, which costs a tremendous amount of money over the lifetime of that one person.
Correct, but we've actually found it is not actually cost effective to just avoid the decay event front. And mainly because, it also depends on the type of screening you focus on, right? I mean, if you do a subgroup of people with genetic risk scores combined with screening at one point in time for autoantibodies, possible, you could make it actually budget neutral. In fact, we're presenting those exact scenarios in an upcoming paper that we're going to publish probably in the next few months here. But generally, the reason many of those are not cost effective is because we're not looking at the lifetime outcomes, which are really a function of the intervention. So it's less about what the result is up front. It's more about what does screening do for people over a lifetime. And if we're not capturing those, then we're not really comprehensively looking at the value of screening. And in your numbers, I mean, 50,000 might be what a hospital would charge, but generally the difference between those with a DKA event and without, from a cost perspective of what the resources used to actually treat, are much closer to 10 to 20,000 US dollars. So if you imagine you're only looking at 10 to 20,000 per case for DKA, and that's less than 1% of the population with incident decay in childhood. And then of those, you're looking at half of them having a decay event. The cost savings actually aren't that great. When you look at, I'm going to screen all of these people for $100 a pop, it starts adding up pretty dramatically. So that's why, in a sense, I have a job to show those different scenarios, to give people an idea what are the trade-offs, not to make the decision about uptake of screening or not. It's simply to display the trade-offs and then let people make the decision. That's my job, is to provide the evidence to make better decisions. And right now, the evidence hasn't really been presented in a way where people can make a decision on screening.
I think a lot of the insurance carriers, they also go off of the mindset that I'm paying all this money now preventatively in this child or whatever, young adolescent, to prevent something that's going to occur in 20 years. They have my insurance for 15 years and the event happens at 16 years, which is on some other insurance company. I paid everything and the other guy, he benefited from it. Thank you very much. So I won't do it.
Yeah, unfortunately, that argument falls flat when you consider the opposite, right? Where you could actually have people that were screened that weren't in the program, in the health plan, and then came in later in life, and then you received the cost savings. So that's kind of it's interesting to play that game, but you have to do it both ways. You can't just say, I'm only going to be losing members when these companies are staying in business and clearly people are paying premiums. So it's either you're losing members to a point after you spend and then you run out of business, which is why should you even care in the first place? And then sort of second is you can also imagine people coming back into a health plan, paying into the system, and then, think of the person that, and this actually came up at a conference from a health plan manager who said very bluntly, what if I give this person a cell and gene therapy for $1 million and then 2 weeks later they get hit by a bus and die? I mean, and the question was pretty blunt and pretty crass, but in the end, that's the job. If you're going to be an insurance provider, that's your job. And you should be modeling out all of the different scenarios of risk, because that's literally the job, is risk protection and financial risk management. And that's what you're offering your plan members that are paying into the system. And that's what they should be receiving, is if I have a huge event, I will get refunded or reimbursed for that big event. And I'll get some level of coverage consistent with the policy that I read when I signed.
Yeah. Now, it gets even more complicated. This is where I really struggle. So, and I use it as an example, the polio vaccine. The polio vaccine, each shot costs about $20. They give the pediatrician about $10 to give it, and say the whole office visit's paid for polio. So, and we give about 4 vaccines, so it's about $500, and there's about 3.5 million kids, so you're spending $1.5 billion. But since the 1950s, there are no cases of polio. So there's zero spent on polio. So you cannot really, using the formula, the incremental cost effectiveness, show that there's improvement. It's just a $1.5 billion spend on polio vaccines and no savings.
Well, you would use the historical.
Yeah. Go back to the 50s when they had it, 60s.
Polio still exists around the world, and families travel all over the place, and children go with them. And if you end up contracting polio, then there are some pretty serious negative consequences. So if somebody was doing an analysis and didn't include the negative outcomes from polio, then I would say they're really not doing it right.
So the last time we had data was 1953, 1,500 kids died in America from polio. And this is where it gets very interesting listening to you, because before I listened to you, I would have thought that, well, the easy formula for somebody who's not very smart, if they die at 10, and they lose 40 years of productiveness times $60,000, that's the economic impact of losing a life early on. You use something even more interesting called quality adjusted life years.
Yeah, well, we use a multiple multitude of outcomes. So quality adjusted life years, one, we also have life years. So just the number of life years that you live that extend your life. We also use clinical outcomes. So say cost per DK event avoided. There are a variety of different ways to quantify the value, but the reason why cost per QALY became so popular is it's used by health technology assessments organizations around the world. What they do is, they have national. So imagine if you have the FDA, and on top of that, you have an entire separate regulatory arm that just reimburses for drugs. And they negotiate directly with manufacturers and say, our country has 80 million people and this many people with the disease. This would be your return, but we can't afford at the price that you have, sent or that you're pricing out in the US. So we need to negotiate. Quality adjusted life years are, in some cases, really in Britain used explicitly for recommending coverage and reimbursement for certain. But a lot of people here have a negative view of quality adjusted life years because of some misinterpretation of the application of cost effectiveness. So to give you a background, Health and Human Services has essentially banned the use of the QALY, but really what they're banning is the comparison of different populations to each other. So, for example, if my job was to go out and say, I need to buy population health, right? Like my job is to go out and maximize the number of life years that we need to live, right? And I'll explain QALYs exactly in a minute, but just to kick this off, we were to just go out and buy, like that's my job and I need to maximize health. Although I'd argue a lot of places in the US are not, it's really not their primary objective. But other countries do have that objective. You may enter into a scenario, a lot of which you were just explaining around vaccines, and say, what if we could either allocate a very expensive cancer treatment to persons over 70 years old, or the same treatment to persons less than 10? That would be an example of discrimination, where you're discriminating and saying, we're only going to cover a therapy for children, and we're not going to cover a therapy for persons over 70 years. And the US government believes that the QALY is the thing doing it. It's the thing that would display, say, for example, the person at 70 has just less life to live because mortality is one. But we're all going to die at some point. And children that start at 10 have a lot longer life expectancy. And the quality adjusted life here combines the length of life with the quality of life that you live, so that if an intervention not only extends your life, but it improves your life by avoiding retinopathy or neuropathy, like a leg amputation or chronic kidney disease, you give that intervention the quantity of improvement, not only in terms of the length of life, but also in terms of the quality of life. And the US government has misinterpreted this application to think that we would say, I'm going to compare that person with chronic kidney disease to children with cancer, and it's going to be a real easy decision because letting the person with CKD die is much cheaper than keeping them alive. And instead, I'll divert my resources to children. So,
And I'm going to interrupt you there just for a minute, because that is how Canada, England, Costa Rica manage their single payer systems. They do these budget analysis all the time. They say, we got X amount of money to spend. We could give these many vaccines, which keep our population healthy, or we can expand the life of a person with dialysis for another 3 years. There's not enough money for both buckets. So they skew towards preventive medicine and the longer time horizon.
It's not as dichotomous as you make it there. It's more restrictions similar like in the United States, where you would let somebody get to a point where there's an intervention to save their life and you're going to do it, and versus we're going to prevent this whole group of people starting at a much lower severity. And then we'll still fund the children with cancer kind of So it's a
Well,
little
I'll
bit
push back because I
more.
was in Costa Rica. And when I
Oh,
was in
sure.
Costa
Yeah.
Rica, I'm 58 now. When I was in Costa Rica, if you got, if you had chronic kidney disease that needed dialysis at 55, you were out of luck.
Sure.
You would
Yeah.
not get dialysis.
Yeah. I think,
And that because I'm 58 today, well, back then I was 20 years old. So it
yeah.
seemed like a little bit cruel. And when
Yeah.
I asked my attendant, he's like, dying from kidney failure is not too bad. You just go into a coma, then you die. That's what he said. I'm like,
Yeah. No,
hey,
I
aren't
know.
we here to
Yeah.
keep people alive? He's like, we can't keep everybody alive, Dr.
Yeah.
Bromley.
No,
So, but to me, now
generally,
that I'm 58 and I go like, if I develop chronic kidney failure, I'm done. I'm done. No kidney transplant, no
unless you can pay,
dialysis. I'm done.
unless you can pay for it out of your
Right. But most people can't afford $200,000 and
yeah.
then the $500,000 for the transplantation.
Yeah. Look, there are examples where, yes, it is actually implemented that way. I don't believe Costa Rica uses quality adjusted life years, but the point is, it's really not the quality. If you,
No, it's a budget. It's a budget
it's simply
decision.
the decision to say, we're going to buy health. And, most countries that do that have it. I'll say there are at least a few countries that have done the exercise of asking their citizens what they most care about. And like in the UK is a very good example of people use it as a very negative example in the United States. But they went out and they directly asked their citizens, if you would rather have a child survive and have a chance or a person over 70, you had to choose between the two, the overwhelming majority said children. And so they actually asked them that question instead of just making the decision without even asking the question.
Oh, you're absolutely right.
States, we don't really do that. We simply pretend like we can provide all of the care, but we're doing the exact same thing. We're just not providing care to millions and millions of people that don't have insurance. They just don't have access to care. So everyone in the United States loves to say, oh, in other countries, they're making these decisions. We're doing the exact same thing. We just choose not to acknowledge it. We just don't cover a bunch of people with insurance who ultimately don't have access to healthcare. So,
you're absolutely right. You're absolutely right. In Costa Rica, if you ask the average Costa Rican, they would say, I lived a good life, give the money to the kids. And that's why their literacy rate's like 99%. It's ridiculous. A small country, and the U.S. the kids can't read at third grade level. The Costa Rican kids are graduating speaking English and Spanish. But that's intentional. Yeah. That's what they want. Right. And they will say, I've lived a full life. One time, if I'm over 60 or over 70, let's keep the children healthy, and that's in their culture.
But remember, if I may, these are not economic decisions. These are ethical decisions, right? So everything that you're talking about now, and it's all been blamed on the quality of life here. These are all ethical decisions where you walk in and you say, we are willing to make the decision to cover children and not greater than 70, in terms of persons with greater than 70, or let's say kidney failure using that. And the example I always give to our students is in the United States, we give a whole group of people, the largest group of people, basically anything that they want, or I'll say the most that we can afford to pay into the system as citizens, as well as the return that we get. And then we're giving a whole set of people, a smaller group of people, absolutely nothing. In fact, you can argue negative health outcomes. Whereas in Britain, Canada, Costa Rica, they're giving everyone something. And they're giving everyone that little bit of something to at least say, if you make really good decisions and you take care of yourself, you should live a really long, full life. Things happen, right? And there are diseases that are inherently genetic or environmental, and some things happen and you have an accident. And maybe it doesn't work out for you. And that's the luck of the draw. But we're going to give everyone a little bit of something. And in the US, all of us on this podcast right now have been given really almost unlimited medical supply. And I'm saying that all relative to other countries and other areas of the world where they're not given the same amount that we're given. But yet, walking down the street, you'll find somebody that's been given absolutely nothing. So we've already made that choice as a society to say, we're only going to give certain people the choice in their healthcare and other people have no choice.
Well, in Virginia, Medicaid is a program to restrict access. And, you cannot argue because they pay less than 50% of Medicare. And so what happens is they essentially, in economic terms, they defund the marketplace.
Yeah.
If you pay too little for a service, then no one enters that business line and people exit that business line. And then zero is spent.
Right.
Now, it's foolhardy in education or in healthcare, because if you don't spend anything educating children or keeping children healthy, you're going to have to pay a bigger bill down the road. But in today's budget, when the legislature meets and they're looking at what they're going to pay for Medicaid, the less they pay the pediatricians and the doctors in their offices, the less supply there is, the less demand there is, and the less access there is, the less spend this year.
Yeah.
Foolhardy. But that's how Medicaid works in many states. It's meant to deny care to people. And it's regrettable, just regrettable.
Yeah. Again, that's an ethical choice, especially considering the federal government has stated they will fill in the gaps of the funding over and over and over again ever since the Affordable Care Act was passed. That was the deal. If you expand, we'll cover the vast majority of your bill for that expansion. So that's not economics, truly ethical. And I agree with you that there's of course there's a budget involved and they don't want to spend money, but if you're not spending the money and the federal government is picking up the bill, there's really no other option to say you just simply don't want to do this. And that has nothing to do with economics. It has everything to do with just, not really caring. And I have to say, people like to blame the QALY for being discriminatory. That's a direct discriminatory act towards people that don't have an income to be in a private marketplace, but instead have to be forced into Medicaid.
Yeah. And in fact, the chapter of the American Academy of Pediatrics in Florida sued the Florida government for that. That said, if you're not paying at Medicare, in essence, you're discriminating against these children. And they won. And, that's why Medicaid in Florida is at parity, because it's an act of outright discrimination. And because the government is sovereign and has sovereign immunity, they can get away with it. But anyhow, let's go back to QALYs because it's really interesting to me. So I have a couple of questions about QALY. So say the polio example, and let's just use simple math, right? So just say that every child would get polio and die at 10 years of age, and they're going to live 70. So do I say that's 60 years of quality life that I improved by vaccinating those kids?
Yeah, the only difference there, so what you just explained is life years gained. So we're just looking at the difference in life years. Where the quality adjusted life year gained comes in, or the quality adjusted part, would be we would also account for the burden of disease until death for those children. So all of the burdensome symptoms of polio would also be included, so that essentially the intervention, the vaccine for polio, would account for the quality of life improvements of not having polio. And then in the future, we would just fix that value and say, on average, because they've done population-wide studies, I helped with one that was applied across the country, where you would say, here's the average quality of life for somebody that didn't get polio, and we would just track that over time. And really where the quality comes down is, imagine that if it's 0 is death and 1 is perfect health, there's somewhere in between that people reside in, right? In terms of day-to-day quality of life. And the average American is about a 0.85. And that's measured using different instruments, different survey approaches, or understanding what people's trade-offs would be in certain health states against living what they would perceive as a perfect year of life or perfect health. So what you described was the life year gained part, but we would also want to include the quality part, because as far as I know, and like you mentioned, it's been so long since we've seen a case of polio in the United States, but you know, it is pretty burdensome before you pass, right? It's not exactly a treat to be having polio, not that any disease is, but some are more tolerable. And, some interventions like the polio vaccine are completely breakthrough and just totally change lives completely. I would also argue you could put, clean water up there as being one of the best, most cost-effective interventions I've ever seen.
And sewer and trash collection.
Yes, right, exactly.
No. But the reason I said, 60 is because since we don't see in the U.S. polio at all anymore, thank God, and that's all due to the vaccination, then every child that gets vaccinated lives at a 1 QALY because they have perfect health from the perspective of polio. And so what I'm trying to get is, how do you do the math? So if you just entertain my thoughts, so 60 years of perfect health would be 60 QALYs?
Well, 60 years of perfect health would, yes, be 60 QALYs, or just life years gained. So if you didn't want to include the quality component, you would just treat each life year as one. So you would get the same answer as a life years gained.
And then would I multiply it by that historical number of 1,500 cases that are no longer going to die? Is that the math?
Yeah, well, you would take, say, like an average survival. If you said it was 10, you would then subtract the life years gained. So let's just say 60 minus 10. It's a little bit, there are some differences because how we're presenting the information is in present value. So I won't get into it, but we discount the outcome because we want the benefits now, not in the future. And so just think of it as net present value. So you would have some difference in quality adjusted life years for those with the vaccine in terms of polio. So like a population, for example, if you were just to average polio cases in the population and then average no polio cases, the difference between those two would be the difference in quality adjusted life years. And then in the numerator, you'd have the difference in implementation of that in terms of, the cost of screening or the cost of the vaccine versus the cost of no vaccine.
I'm curious, at the insurance level, do they even have an understanding of what you're saying?
No.
I mean, it's really hard.
It is, but that's my point is that when we vaccinate, we just don't give a shot. We're saving billions of dollars because we don't see polio.
Given a shot to get to school. That's the culture. That's the mentality today.
So the reason I wanted Dr. Quinn on the show is to try to help fellow pediatricians
Not a shot.
speak the math. No, if we vaccinate for polio because we don't see polio anymore, we're doing it 3.5 million times every year. That's how many QALYs, which times $150,000 per QALY. That is the savings that we're bringing to the table. We're adjusting it to, like you said, for now. That's how much money. It's like $15 billion.
Yeah.
Because a QALY is worth $150,000. So don't tell me you can't pay me at CDC price list for the polio vaccine when we're saving $15 billion and we're spending $1 billion. And this is going to accrue to your bottom line because you're not going to have this expense of patients that are on your rolls today, or the people that switch jobs and now they're insured by you because they were working for Amazon and now they're working for Apple. They're still coming to you to be insured. And if that kid gets polio, now or later, you're saving the money. The insurance company, you are saving the money. The pediatrician's not getting any of that money. The parent's not getting any of the money. You, Mr. Insurance Company, or self-funded, you Apple, you Amazon, you Google, you're the one saving that money in the long run. You, government of Virginia, you're saving that money in the long run. So don't tell me you can't afford to pay me what that vaccine is worth. Don't tell me that you're not going to pay me for the second antigen because, it's just a shot. No, I'm helping keep costs down every time I give a vaccine.
Correct.
And that's, how do you, and then unfortunately what happens is when we negotiate we negotiate with the lowest man on the totem pole. They can barely speak English, let alone do math, and forget it. They're not going to be able to do algebra. And
they're the guys that's supposed to go to Mr. Insurance Guy and present your case. So if they like you, they may take what you said, and if they understand it halfway, present it and make your case. And then they throw in some budgetary numbers or increases or take money from here and put it into here to make you happy and go away.
Yeah, but
first, the pediatrician needs to respect, understand, and present the value that they give. They don't do checkups, functional heart murmurs, and give shots to go to school. That's not our job.
And because you're in that Academy of Pediatrics committee, I want that committee to adopt this language that Dr. McQueen is talking about. Because when you talk to national payers, you should come in with, your holster full of bullets. And the bullet is not, you're ugly and you're mean and you make too much money that I'll never make. The bullet is, hey, as a group, family doctors and pediatricians, we give this polio vaccine, very inexpensive intervention, and we're gaining this many QALYs, which accrues to your bottom line and to your stockholders and to your C-suite.
Yeah.
So you can afford to be a little more generous, because then we're changing how we're talking.
Yeah, I don't actually think they're arguing with you about polio vaccines. I think they're arguing with you about their budget impact elsewhere.
Yes.
This is what happens, is something like 80% of spending is from, 10% of the population. So every time we include, a really highly expensive therapy, and I can speak to this just knowing that it is incredibly challenging when there's a blockbuster drug that comes up that fills a huge unmet need. And for 100 people, it will take up 20% of your budget. And then you're sort of in this position where the patient advocacy group is on you about covering it, and you're publicly getting, destroyed, publicly saying, oh, you're not going to cover these. And then the trade-off is, well, I'm going to have to not cover something somewhere else. So then they're going to come and be like, why are these vaccines? Why are we paying for this stuff? And I think generally, I get what you're saying, that do payers understand this? They absolutely do understand this. In fact, budget impact is pretty standard. Really, I'd say where we, and I say generally human beings, and especially people in the United States, just really don't understand trade-offs. Nor maybe do they want to understand trade-offs. And I've had experience with that because, I'm on the advisory council of the Colorado PDAB, which is a drug affordability board on, putting, say, upper payment, they call it, on certain drugs that got kind of out of control in terms of spending, at least defined by the state in how they define that. So I think what you're seeing is the consequence of the approach, which is, let's just try to cover everyone that comes in our plan. Let's try to meet everyone's needs. And back to some of our earlier cases that we talked about, which is, in some countries, they just admit that they can't cover everyone. And they're direct with people. And it's embedded in their society with how they talk about it, right? But I specifically know people here that have said there's never a funding problem. We have money for endless wars. There's always something, right? And then it's the CEO got $30 million in their bonus last year. I mean, all of those things are true, but they're not necessarily going to help the person that's sitting at the insurance company, as you said, in the lowest, totem pole person, understand why you should cover their, whatever intervention that you're trying to implement. So in my opinion, the better thing to present is a budget impact with the health consequences. So for example, if someone was arguing with you about polio vaccines, I have to say, maybe anecdotally, this happened to you. I cannot imagine this is happening nationwide with.
It is. Because I was in the room in the negotiation, and I wanted to go across the Zoom screen and choke the person.
Yeah, I mean, that seems.
Which one was that?
It's
You don't
a
have to tell them. You don't have
it's a company that was acquired by a pharmacy.
Okay, I remember that one.
Yeah. I mean, whether that's happening to every health plan, I don't know. That's certainly not what I've heard, and certainly not the experience of Colorado. I'll just say that.
Yeah.
But what really helps is to understand, again, take that historical data and say, this is actually what happens to people when you get polio. And there are still polio cases around the world. And we even did research, this is a couple of my colleagues did this. They demonstrated that the reduction in measles and mumps vaccinations in Colorado, because there's a small cohort of families that are anti-vaccination and decided not to get measles and mumps vaccines. They were able to, I wasn't on the paper, actually quantify the population effect in the Metro Denver area. And it just shouted out, like, you should get your children vaccinated for measles and mumps. This
Rocket science.
Because it's not only a consequence on you, it's a consequence on some other family. And, we're a parent of a young child, and our stance is we're not hanging out with people that aren't vaccinating their children. And end of story. And people can have their own opinions, but we can have our own choice over who we get to share time with and who we get to play with in terms of toddler playtime. So I think it's really important to demonstrate how many cases of polio would happen, what would happen to those people, and how quickly it might actually spread in the population. And then you could talk about sort of the budget secondary. So this is my consistent theme. I said this at the last diabetes symposium in Colorado. The number one thing that you need to talk with about insurance companies is unmet need. And the fact that if you don't do polio vaccination, there will be an unmet need that you could have prevented. And just make sure that's crystal clear in understanding this is what happens if you don't vaccinate for polio. And we're doing the same thing in type 1 diabetes.
Yeah. Yeah. So I love the quality measure. I think it's a good way of measuring impact over the course.
I'm surprised to hear you say that, because most people despise it. And the general attitude is that it doesn't make sense, even when I explain it. And we're still battling to even, Health and Human Services is gone. They basically have this tiny little language, this cost per quality or similar measure. And then now they've essentially taken our entire field and said, well, we really shouldn't be doing this at all, which is really just furthering the problem of, well, how do you know what is high value and what is low value? For example, one of the big examples we use are cell and gene therapies, where you could have a cell and gene therapy. It's not necessarily curative, but it could relieve you from the healthcare system and spending for 10 to 15 years for, say, a hemophilia patient. We published on this. And there's even a point where Medicaid breaks even after about 5 to 10 years in terms of spending, because prophylaxis treatment is that expensive. And no one really knew this until you do the analysis. And there were no QALYs involved. There's none of that. It's just, regardless of whether you use the QALY or not, it's simply about us and understanding that, every single day, the decision that you two are making as physicians does have a trade-off for someone's life. And it's hard to go through every day thinking, right? But we have trade-offs in every aspect of our life. If you take, and I think about this all the time, I got into an accident. It was very snowy in Colorado. My son was in the car, and we had our dog in the car, and everyone's fine. It was just a simple fender bender. There were 2 to 3 different ways to make it to his daycare. What if I took Route 1 instead of Route 2, or Route 3 instead of Route 2? What would have happened? I think a lot of people have that retrospective, right? What decision could I have made that would have changed the outcome? But rarely do we find people prospectively asking the question, what if I were to do this versus this versus this? What are the potential different outcomes? Because it's really hard to think of risks and benefits moving forward. Everyone's just trying to make it day to day, But that's ultimately what we try to do very imperfectly, try to understand what are the potential avenues here. And how do we present this in a way where people really understand it?
Plus the other, I think, I'm not an expert, so I'm like in very, very thin ice. Any moment, I'm just going to fall into the lake. But I think because of what you said, I say two things. One, everybody goes to an orthopedic surgeon for the knee replacement when it hurts so much they can't walk anymore. Right? It's just unbearable pain. Do whatever it takes, doctor. Make my knee feel better. Okay. But very few people are willing to go to the gym and, do water exercises for 30 years to prevent that knee from going bad. Very few people are willing to watch their diet so they're not overweight, so they don't put too much strain on their hips and their knees because they don't feel real pain. They wake up every day, they're 350 pounds, they walk down the stairs just like they did yesterday and the day before that, and they open the refrigerator and they eat and they're happy, and then they get dressed and go to work. And it's so hard for humans to understand long-term consequences and long-term payouts.
Of course.
It's very difficult for us to understand that. And that's part of the problem. When you just take all the emotion out of it and you say, here's a mathematical formula that measures everything equally based on what you feel is a decent way of living. And everybody's going to be different, right? I personally don't want to be trached. I don't want to be in a nursing home with a trach and a G-tube. Other people might say, yeah, give me everything till the moment there's nothing else to give me. But then you take the emotion out and you're like, okay, this intervention has tremendous potential. That intervention has halfway potential. And then that other intervention really doesn't have much potential. So now as a society, how much are we willing to spend? Because when you tell me how much we're willing to spend, I can tell what priorities we can get down to. And that's how we do it in the US.
Yeah. But I think you're speaking to people wanting satisfaction now versus satisfaction later, right? People want things now. And we actually, that's when I explained that present value, that's what I meant. We want the health benefit now. And to some people, the benefit is I just want to smoke after work because it makes me feel better. I want to drink 4 to 5 drinks a night because it makes me feel better. I want to eat whatever I want because it makes me feel better. I mean, the example that I always give people that I find just astounding and totally contradictory for humans is there are a whole group of people, rightfully, I think, in part, very concerned about the future adverse effects of the COVID vaccine, specifically the mRNA. Yet when it came to Ozempic, it was like, not only give me Ozempic, but give me the compounded semaglutide at some weight loss clinic in the back alley of, some random strip mall. I'm totally fine doing that. There clearly are no risks to that. In fact, there are only benefits of me losing weight. And that was both occurring at essentially the same time in terms of when the drugs were released. I think in both interventions, people should always be concerned with adverse events of any pharmaceutical product. But let's be honest, it was completely outweighed. And if you looked at the difference in the survival curve for COVID RNA vaccine in the largest trial in human history, there were some people that simply couldn't be convinced. And seemingly the same people are convinced about Ozempic after a very similar, well-done trial, yet have no concern whatsoever on the risk. So people want to be satisfied because, and especially in our society, they want to look better, they want to lose weight, and they want a quick fix. They want to be satisfied. It's unfortunate, but I always use that case example because it shows the contradiction of the human mind, and especially of a society like ours that is nothing but take, and want it now. I want to be satisfied. And it's unfortunate, but it's just the truth.
Yeah. And that's behavioral economics. That is behavioral economics. You can tell people like, do this, do that, and you'll have a better outcome. And they're like, nah, thanks for the advice. Not doing it.
Yeah.
And like I hear this all the time. I grew up in Ghana and I got none of these vaccines, and my husband and I came here. We're healthy.
Yeah.
Well, yeah, I rode in the back of the station wagon from DC to New York, and my dad didn't get a ticket, careless driving, reckless driving, and I didn't die.
While
Yeah.
he was smoking in the car.
No, Dad never smoked. But you know what? When now we know that we have safe seatbelts, airbags, why would I miss out on that protection? For what reason? I mean, the seatbelt doesn't really bother me. So why would I just,
Right.
it's just stupid. That's just like, I'm asking for trouble. For what reason?
Because somebody told you to do it. That's why.
Yeah. And you would really like the other aspect of our work, which is we get people together and ask them these questions. We give them different trade-off scenarios, and you could see their eyes light up when we essentially display the contradiction right to their face, and it slaps them across so hard, and they have to now admit that it's so clearly obvious that they made the wrong choice. And it's not to, it's not to be negative towards them or insult them. It's simply to show that even the human mind is really focused on either what satisfies you now or your, what we would call your prior beliefs and what you think is true, even if it's not really true. And you can prove it to them that it's not true. So that whole aspect of our work is different than quality adjusted life years, but we still have this aspect of the trade-off. And can we display those trade-offs in a way that people really understand? So in that way, as you could tell, I really love my job because
it's very interesting.
Really do change people's mind. And in other cases, it's just ramming your head against the wall. Everywhere.
So I have a story that I'll never forget. This was in Michigan State University, and I saw a child with a Wilms tumor, and he looked like he was 5, but he looked like he was pregnant. And I came out of that room so angry, and I told my attending, "What's wrong with these parents?" And John Whittinghill was in his late 60s, had practiced for a long time. And he took me back to his office, sat me down, and he said, "You only see what you saw yesterday in the mirror." So that parent doesn't see any difference in his kid because he looks just like he did yesterday. And that's as far as his memory goes.
Mm-hmm.
That's why we have growth curves. That's why we plot the kids, because then you can see the difference when you measure. And that's one of the fallacies of humanity. As long as you look just as well as you did yesterday, nothing's changed. And, so it's not the parents' fault. It's just they're seeing the same thing as yesterday. Yeah. And this was in 1989. And those were some of the wisest words I've ever heard anybody tell me. And that's why people gain weight. That's why people get into so many different problems, because they're just seeing their version of them yesterday and their version of them today, and they look pretty much the same.
Yeah.
So anyhow, I have one more question, and I'll be mindful of your time because George just loves this. And it is how you're using AI and computer modeling to get to all these outcomes in your research.
Sure. Yeah. So I think AI is a really broad term. What we're doing is more couched under machine learning. So AI, in my opinion, I think the idea of AI is, deep learning where you're possibly even, which we're not really there yet, where our sort of AI environment is solving new problems that we've never really solved before. What we're doing here in our work is using machine learning algorithms to optimize scenarios which make it really difficult for the human brain to handle. What I mean by that is once you move beyond islet autoantibody screening for type 1, right? So you have the environmental part of the transition to diabetes. Once you add the genetic component, once you add other variables beyond just family history, once you start looking at age, frequency of screening, all of a sudden you have somewhere between 1,000 to 3,000 models or strategies, screening strategies. So that could be, islet autoantibody screening at age 5 once, autoantibody screening at ages 2 and 6, but using a cutoff of genetic risk score screening to say we're only really going to second screen a really high risk group of people that were really high risk from the genetic risk score. And then you could have kind of anywhere in between. And this is a preview because this is what we're publishing in our paper, hopefully. And you saw some of this. But the what we would call multi-objective optimization or machine learning solves this for us in about 7 to 8 hours in the population. Whereas if we were to do that, we would have to walk through each iteration as a human and say, which one not only is feasible, but also which one is optimal. And then really what happened historically is that people would just pick out what they think is best. So what a researcher would think is best. What we're trying to do is bridge the gap to say, we'll give you a bunch of different scenarios, but we want to talk directly to pediatricians, to even insurance companies, to every stakeholder and say, what's most feasible? We're going to give you 3 or 4 different options. And then if you want, you can go and look at an appendix where we have all the different options that were solved in a similar sort of way that we did those say 3 or 4 examples. So machine learning really helps us do that. I wouldn't really call it AI though. It's a optimization where we can optimize multiple objectives at the same time. What are those objectives? Like I said, interactions with screening. So age, frequency, whether we had variables for genetic risk, offsets in DKA costs. So how much are we actually going to save in the system? The original DKA cost that you would give to the normal proportion, which is about half children at onset, end up with a DKA. And then you can keep adding objectives, but we have, 3 to 4 objectives that we're optimizing across thousands of strategies.
Wow, that's amazing. Now, in your lecture, you call for everyone and anyone to share the hemoglobin A1C data with you. Why is that important? And what is it? Which hemoglobin A1C data?
So the importance of like we talked about with life years gained and quality of life, quality adjusted life years gained. We know from really long and well-established longitudinal studies, so follow-up from DCCT, Diabetes Control and Complications Trial, to EDIC, right, which is, I think, going on 50 years or more, and the UKPDS, which is in type 2, that glycemic control is an imperfect but very well-established surrogate for complications well into the future. And like I talked about much earlier in this podcast, if you look at those that are diagnosed and not diagnosed with a DKA event, without and with a DKA event at diagnosis, after 20 years, you're seeing spread in their A1Cs that seems to be really stuck. So those with a DKA event have higher A1C. And both of you already know this, but I think a lot of people outside of type 1 don't realize A1Cs are just incredibly stubborn. They're really hard to bring down. And even if you do everything right, you could still have one bad month or bad 3 months, and then you end up right back to where you started a couple of years ago. It may seem like maybe, how does this guy know this area? I actually did my dissertation in the Barbara Davis. So I work directly with patients. I'm not your typical health economist that just does the numbers in the background. I've actually talked with patients, numerous, surveyed them directly, been engaged with, in even some aspect of their care, like with CGMs. So I also have some topical knowledge, although it's very imperfect because I don't have the biomedical science background. But for example, if you went to Annette Ziegler's event talk, at the same session I gave my talk at the American Diabetes Association, they're finding after 9 years in FRIDA, the screened versus non-screened group, there's a difference in 0.4 HbA1c, difference of 0.4 in HbA1c between screened and not screened, not even the DKA versus DKA. This is a randomized trial that is showing a major difference in HbA1c after 9 years, which no doubt, as those patients know, is going to affect their long-term complications because we've already established that from the DCT and EDIC and then UKPDS. It's very clear. The evidence is extremely clear on this. So if you don't publish that from the trials like autoimmunity screening for kids and FRIDA, if you don't publish that information, then we can't establish the long-term lifetime cost effectiveness of screening. Then we're just right back to, well, are you going to offset the costs of DKA enough to overcome this financial hurdle, which, again, I had this theme throughout, I think is the wrong way to look at this. This is an ethical decision to reduce the burden of childhood disease. So if you walk in with that mentality and you ask the question, how can we pay for this? Through a combination of discounts for volume-based discounts, we're saying, which I think is very possible with centralized testing, along with others on our team. And then subgroups, say in high-risk populations using genetic risk scores, you actually can make it budget neutral, but we have to first walk in and all agree that this is a good thing for children. And if we can all agree on that, then we'll figure out how to optimize it. And that's my job. That's what we do.
Wow. So I just got a little bit lost on what the thought process on the preventive task force, which is, I think there's enough data to show that early screening and potentially lead to better outcomes because you have better glycemic control over 15 to 20 years. So I get lost as to why they're calling for more randomized studies to show the difference. What are they trying to tease out with more data?
Yeah, I think they are trying to tease out more outcomes, but not only HbA1c, but also any sort of childhood outcome like development, educational outcomes, stuff like that, which I think are really relevant. I think the problem with, and I was on this call, maybe you were on the same call, and I asked the question, will they accept glycemic control evidence? And the answer was, well, they're not going to talk about complications from type 1 diabetes. That's about treating type 1 diabetes. So you see right off the bat, somebody coming in who's a physician doesn't understand that avoiding the DKA event, there is a biology behind this that's been explained to me. And I can only repeat the information that's been explained to me by very qualified people. But there is a beta cell preservation that's from avoiding a very severe DKA event. And if even physicians outside of diabetes aren't understanding this, there's no way the U.S. Preventive Services Task Force is going to understand that either. So that's the whole reason we published our paper in 2020 to put out the thought that what if would see this? How cost effective would it be? And it's really interesting to me that qualified scientists are associating glycemic control even within a few years after the screening. They have no concept of how that would be connected to reducing DKA events. That's somewhat alarming to me forward to get this sort of uptake going for routine screening in the United States.
Yeah. I think it's like trying to explain to the insurance executives the impact that preventive care early in childhood has, expenditure later in life in healthcare services, but quality of life, employment, keeping people out of jail, keeping people. The QALY, which I found very interesting, is an alternative which measures wellness adjusted life years. It's not just dollars and cents. If you can get a 5-year-old to be healthy, safe, read and write, even if his job is only going to be a car mechanic, he's not going to be a PhD like you. That has tremendous value to him, his family, the society around him.
Yeah.
And so, and I always use the people that collect the trash because, like we said before, without them, we still be getting all kinds of nasty diseases because the trash was just thrown out the window and the rats came by and we got the plague. So, and trying to explain that and to smart people, and they just look at the other way like, I don't know.
Yeah. I mean, people have told me that at diabetes conferences. Do you really buy that? That A1C will be different, years into the future. It's sort of shocking to hear that, I have to admit.
The data's there. The data's there. I mean,
It's not only there's longitudinal evidence from 20 years, but because it's not randomized, and I think that's the challenge. Like, there's no way, obviously, that you can randomize people to a DK event or DK event, but you can randomize the screening arms. It just makes for really, I think, even in my opinion, it makes for a very difficult ethical challenge because you're going to screen one group, not screen another group. And then, in a sense, you're going to let DKA events happen. And I think that even though they did get that approved in the UK, so there will be a randomized trial of screening. Okay. And Frida, I thought, had some sort of randomized component to it, but I could be wrong. And I'm not an expert in that study, but I can ask because I know health economists that are working on it. But I do find that somewhat surprising that there's not only just like disagreement, there's outright denial that would be the case moving forward from people in the diabetes. So I think there's still a lot of work to do. And that's why I tried to quantify the trade-off in a way that would allow people to set the case by collecting that data. So in our first paper in 2020, we asked the question, what would make it cost effective? And glycemic control improvements through avoiding DKA events was part of that story. And the whole nudge to people was go collect that evidence. And just things take time, right? I mean, all of these population studies started 3 to 4 years ago. It's just going to take time. But the more and more we present that in different samples, it's going to be harder and harder to.
I mean, the ultimate unethical study would be to actually draw the blood, freeze the blood, and after the DKA event, see if they had the autoantibodies at 18 months and 4 years of age, and see what the outcomes are. And it would take 20 years to complete.
Yeah.
And in the meantime, half of those kids would end up in DKA, and some of them would die from cerebral edema, and other ones will have lifetime intellectual impairment because of the DKA and higher cost of care because their beta cells were stunted. So, it's to me, just the thought of somebody calling for that kind of study is unethical. I'm not a researcher. I just read a little bit and try to understand what's going on. But thank you. This is a language,
complicated podcast.
This is a language that we don't speak, but it is a very, very important conversation because we do have to constantly discuss with payers the importance of the work that pediatricians are doing in the country and how it is foolhardy to pay as little as you can get away with for pediatric care. Because in essence, what you're doing is you're eliminating a marketplace that on the long run keeps society healthy and saves dollars in healthcare over the long run. And they don't see it. They really don't see it that way. The big commercial payers see it. This is an expense. If we can lower the cost of per item that we're giving the pediatricians, they'll still do the work. The kids will still be fine. But what eventually happens is you don't have a marketplace, and then the care doesn't get proven.
I mean, you said it, and I'll put it in my terms, that their objective is not to improve the health of the population. Their objective is to manage risk and pay for as much as they possibly can pay for. And also,
I don't know what I think about them pay for.
And turn a profit.
Yes.
Yeah. So that, and that's why in other countries, it is easier to address the question when you say, we're not in this for any profit seeking. These are your tax dollars, and we want to treat as many people as possible. We want to give everyone something, but we don't have that here. So the situation you describe is always going to operate as a problem. Can't state our own objectives as a society. I hope I at least demystified some.
Yeah.
Maybe it doesn't seem like I have, but I try to use some ways of framing it to, at least in my own experience, sense to some physicians and other folks, but Always happy to follow up questions. Anyone, feel free to email.
Well, thank you.
Thank you.
I find the topic fascinating. You did a great job of explaining it.
Thank you.
It's a fascinating way of looking at what we do, because every time I write a prescription, I have an impact. Either make someone better or don't make someone better, or they get a side effect from it. They're actually worse than when they started to see me, and it has a cost to society.
Yeah.
Because even if it's a $5 amoxicillin prescription, someone's paying that $5, whether it's the parent paying it for cash, the state of Virginia paying for it, or Google paying for it, us, all of us collectively in our insurance premium. We're all paying for that $5 prescription. Well, thank you. Stay warm in Colorado. Hope to see you in person sometime somewhere.
Absolutely. Thanks for having me. Appreciate it.
Thank you.
Okay.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.